Yes,
We're live on Facebook Live. You guys, we're live on Facebook Live. As promised, I'm Tara Marie. We're pre-recording my podcast this week, and so we like to share the pre-record with you on Facebook Live. This is my esteemed guest. This is Dr. Ofer Jacobowitz. He is an internationally renowned physician, surgeon, and sleep apnea and snoring expert. And I particularly wanted to do this show because so many people are walking around with sleep apnea. They're not diagnosed. It can be very, very dangerous. This was something that Chad was interested in. A lot of people were interested in it. So we want you to feel like you're part of the show. If you have a question while I'm interviewing Dr. Jacobowitz, please post it in the comments section. And Chad, you'll keep an eye on that. Chad will keep it. Oh, and everybody, Chad's here.
Hello.
They always ask about Chad.
I always love this before production part because people get to see us in the mix here.
In the mix. Chad's here. Yep. Chad's here, my producer, my wonderful producer. So if you have a question while I'm interviewing Dr. Jacobowitz, please post it in the comment section like as soon as possible so Chad can see it.
Yep.
And because a lot of times what they do, Dr. Jacobowitz, is they post the questions after everything's done. And then I'm left to answer questions about medical treatments, which is not good. Okay, so we're going to get going. Chad, are we ready, darling?
I think we are.
We have to do our little screen grab thing.
Yes. Okay, so let's do a screen grab.
Okay. All right, so doctor, what we do is we pause just for a second and we pause, play to the camera, smile, and then we use that as a cover image on the videos. Okay? So let me close this. Okay, one, go. Let's do it. Okay, Chad, I'm going to do one more.
Okay,
Can I do one more?
Yeah.
Okay. Okay, I think we got it.
I do too.
Okay. So
next thing is I just
got to do the clap.
A single clap, please.
Okay.
All right, and with that, we are ready to do a great show.
We forgot to clap the last time, Chad.
I know. I can still do it without, but the clap makes it a lot easier.
Yeah,
there's a reason they do it.
Yeah, I know.
But it makes it a lot easier.
All
but
right.
not having it's okay.
Yeah.
They're algorithms. All right, have a great show.
Okay, should I just 3, 2, 1 it? Okay. 3, 2. Well, hello and welcome to Tara Marie Live. Thank you so much for tuning in today. I'm your host, Tara Marie Segundo, and I'm a fitness expert, a personal trainer, and a motivational strategist. And as usual, I'm coming to you from the Hangar Studios right here in New York City. Tara Marie Live is a podcast about mental, emotional, physical, social, and spiritual health. So we bring you cutting-edge information that we hope will positively affect your health and your life. Now, today we're doing a Facebook Live simulcast as we pre-record my podcast. So we welcome everyone out there on Facebook. Our topic today applies to so many of us, and many of us are not even aware of it, which makes it especially scary. We're talking about sleep apnea. Now, we all know what it's like to be tired after a sleepless night when you can't fall asleep because you're under stress or your kids are sick or something else keeps you awake. But what if you do get sufficient sleep and you're still always dragging yourself around exhausted? This is typical. This is the typical scenario for people with obstructive sleep apnea, also called OSA. The word apnea literally means without breath. And people with sleep apnea have pauses in their breathing during sleep, which causes them to just briefly wake up, usually without even realizing it. And the result is that they feel very sleepy during the day. Now, in the long term, this increases the risk of developing a lot of very serious illnesses. And obviously, it can have a huge effect on quality of life if you're always walking around exhausted. When it's left untreated, this is the scary part. When it's left untreated, sleep apnea can cause conditions like high blood pressure, cardiovascular disease, weight gain, memory problems, depression, impotence. This is serious. Type 2 diabetes and headaches, just to name a few things. Untreated sleep apnea can also cause, obviously, job impairment and car accidents, or if you're a truck driver or someone who relies on being awake for your job. Fortunately, though, sleep apnea can be diagnosed. It can be treated. There are both medical and surgical options available. So I'd like to welcome my guest expert for this week. It's Dr. Ofer Jacobowitz. He's an internationally renowned expert in obstructive sleep apnea and snoring. He conducts research on the surgical treatment of sleep apnea and nasal obstruction, and he consults for new technologies and treatments both in the U.S. and abroad. He's an international speaker and course director on sleep apnea and nasal obstruction. He's been named as a New York super doctor, top doctor and most compassionate doctor. Dr. Jacobowitz practices right here in New York City as a partner and co-director of sleep at ENT and Allergy Associates. Doctor, welcome.
Thank you so much.
We are so glad to have you. And Chad, I might as well tell the kids in Facebook land the story about how we met Doctor,
Please
right?
do.
Okay. So the way I met Dr. Ofer, you're such a casual person. Okay. The way I met Dr. Ofer, Dr. Jacobowitz, Dr. J, is that I know Dr. Jonathan Aviv, who I've interviewed. When I was on SiriusXM, I interviewed him at least 3 times that I can think of. So my listeners know him. My listeners love him. I interviewed him once since I've had the podcast about when his book came out, the Acid Watcher Diet. And Dr. Aviv said, you got to meet this guy that's in my practice. Chad, remember I told you this story, right? Yeah. So Dr. Aviv said, you've got to meet this guy that's in my practice. He's like a superstar. And sleep apnea is a really hot topic, primarily because it goes so undiagnosed and because it is so dangerous. It's the things that we're not aware of that scare me. The things that we're aware of and on top of, we can manage that. But so many people don't even know. I was quizzing Chad. Chad snores, right, Chad?
Yes.
Chad snores, and I know that just because you snore doesn't mean you have sleep apnea. But like my dad snores heavily, like he's sawing logs. I know a lot of people that snore.
Sure.
And I know that I had a deviated septum that I had repaired when I was in my 20s because my breathing was so bad. So this is something that a lot of people don't really think about because they just think, snoring, and they put in earplugs. So I've been really eager to get you into the studio.
Thank you. So if I might say, so what happens is that when you have sleep apnea and you wake up many times during the night, you wake up for such a short period of time that your brain actually does not form a memory. So you could wake up 100 times a night and you think you slept through the night and you woke up feeling tired. So that's one of the mysteries of sleep apnea, why people, especially if they live alone, don't know that they have it.
Right. Chad, do you think you wake up at night or...
I definitely do. Every 30 minutes I can see that clock. Sure.
Oh, see.
No, I'm the classic case. This show is going to be very educational. I'm going to be listening and taking notes on this.
See, what scares me is and I hate for people to walk around tired. I hate that. But what scares me is all of the stuff. I mean, the cardiovascular risk, depression. People could be depressed and not even know why. People could have heart problems and not know why. And then it's so, if you just trace it back to the source, it's easy to fix.
I agree. And also people, like you said, may have car accidents or accidents at work, and they may not even realize that they're sleepy because they got used to it. They think that being sleepy is the new normal.
Way it is. Well, you did that piece. When we were preparing for this show, you sent me that piece that you did with the MTA.
Right.
The Metro Transit Authority. Yeah. And it was because which conductors were having, was it Long Island Railroad or New Jersey Transit? Which conductors were crashing?
Yes, it's all of them, really. I mean, there were different conductors. There were Metro North, there was Long Island Railroad, there was New Jersey Transit as well.
Okay.
And there were 3 documented cases where they had untreated severe sleep apnea, and that is thought to be the main reason why they actually
they had the crashes.
Crashed. Yeah.
I used to be a flight attendant a lifetime ago. 20 years ago, I was a flight attendant, literally 20 years ago. I'm 53 now, coming up soon, and I was 23 when I was a flight attendant. I'll bet you pilots, like I would be afraid for you. Like when I watched that piece that you did for local news with MTA, for train conductors and such, it made me think back to when I was a flight attendant. And like back in the day, I was working for a charter airline. And so a lot of times they didn't apply the same rules that they do to the majors to us. So we wouldn't have, for instance, a safe amount of time between flights. So we would get someplace late at night, and it wouldn't even be a full 8 hours before we had to be back on the aircraft the next morning. Add in something like sleep apnea for some of those pilots. I mean, I don't know that any aircraft accidents have been traced back to that, but that's what I thought of when I saw that piece that you did. So what came out of that piece, though? What did you do? Did you end up getting involved with the MTA?
So I think the most important thing is public awareness, which was important. In the end, myself and my group did not become involved with the MTA because even though they named us as a company that's going to help them screen their operators, at the end they did not. They chose not to use us. But
are they screening?
So they're screening, but I think as we'll get to probably later as well, they're screening using some very classic sort of criteria, meaning they're looking for the typical, middle-aged, overweight man with a big neck, which is certainly a common type of sleep apnea, but not going to find all folks with sleep apnea.
Exactly. So. Let's just jump right in. Let's jump right in here. How did you first I'm just always curious when I talk to a physician, how that physician got interested in that particular specialty. How did you decide? Because I know you're an ear, nose, throat doctor. Okay, right? So you're an ear, nose, throat doctor, just like Dr. Jonathan Aviv, but then Dr. Aviv got very interested in acid reflux and throat burn reflux, et cetera. How did you decide you wanted to get interested in sleep medicine, especially now it's popular, but back in the day, like nobody was even talking about this 20 years ago, were we?
No, sleep is a very new field. In medical school, you barely, at least when I was in medical school, you barely learned much about sleep. So, but what happens is you do learn and you do know that people have sleep apnea. But it wasn't really clear to me what's the best way to treat people. So I completed my residency at Mount Sinai. I went to practice. And before you know it, you realize that how many of your patients actually have a small upper airway and are at risk for sleep apnea. And all you do is just ask them a question, are you snoring? And you find out that there's a very large percentage of people with this problem.
When you say a small upper airway, do you notice that just by putting a tongue depressor down, putting the tongue down and looking? Is that how you notice it?
So you start by just looking at the outside. So I look at people's faces and I look at the size of their facial bones, like the jaws, the upper and the lower jaws. Is the face narrow,
the width
long?
Of the jaw. Okay. The width of the jaw.
Exactly.
Okay.
The width of the jaws. Sometimes a receded chin, for example, also is a sign, or a small upper jaw in other ways.
Okay.
So there are things that you can see from the outside. And then, of course, you can have them open their mouth and look at, again, the size of the jaws. Are the teeth crowded because the jaws are too small? All kinds of little signs, even without a tongue depressor.
Crowded teeth is an indicator? Okay.
It's a risk factor. It just tells us that the jaws are small.
Okay. Yeah. And so you kind of thought this is untapped territory? Is that what you thought?
So what happened is I realized there's a lot of people with this problem, especially when you just ask them, do you snore? You realize they are having some narrowing, which is causing their snoring. And then I got very curious. I said, what do we do for these people? How do we help them? And having trained as a surgeon, I first went down the track of trying to figure out what do we do surgery-wise to help them? And I realized there wasn't a clear direction, that it was complicated.
Okay.
And that attracted me very much to keep going.
Because it was wide open.
Exactly.
And you could actually make a market. I get it. There wasn't much going on, and you thought, okay, I'm going to go here, the path less traveled. Why do we need sleep anyway? Why is it so important? I mean, obviously, I don't feel well if I don't get my sleep, but really, our bodies, we can't function without it.
Exactly. Sleep is important for everything. Every cell in your body, every organ in your body is crying out for sleep. It goes into severe dysfunction if you don't get sleep. So every array, every function of your body is either depends on sleep, is tuned by the sleep clock. It requires sleep.
And things like metabolism. If you don't get enough sleep, you slow your metabolism. If you don't get enough sleep, obviously you can go into a depression. One of the things, if I go for long periods without enough sufficient sleep, I get depressed. It also, you say it has to do with memory, immune system.
Sure. So let's talk metabolism. So if you don't get enough sleep, let's say you're a healthy 25-year-old and absolutely no risk factor for diabetes. If you deprive yourself of sleep, let's say 4 hours a night for a number of nights
in a row,
then your body actually becomes pre-diabetic. You become insulin resistant just from the sleep deprivation. Guess what else happens? The hormones that have to do with appetite actually change. Yeah. So something called leptin, which has to do with feeling satiated and not hungry, actually goes down. And ghrelin, the hormone which increases appetite, goes up. So there's a lot of changes just these are just the tip of the iceberg.
And also cortisol goes up, which encourages belly fat storage.
Absolutely.
So, yeah.
The stress hormone. So that's just metabolism.
Yeah, maintaining weight. If you don't get sufficient sleep, you can't. A lot of fitness experts say that the way to keep your body fat low is diet, exercise, and sleep.
That's great.
That's what I mean. It's seriously, it's diet, exercise, and sleep. That's how you keep your body fat low. You can't just diet. That's why if I have a choice between skipping sleep to have a workout, I'll skip the workout. Now, years ago, I didn't have the same respect for my body that I do now, and I had different priorities. I would skip sleep to get in a workout. Now I'll skip a workout just to get in the extra sleep. Because if you skip sleep to get the workout, you're just kind of canceling it. You're just kind of wasting your time and canceling the workout. Also, obviously, for the cardiovascular system, people who don't get sufficient sleep have a higher risk of a heart attack, a stroke.
Sure. I mean, you just need sleep for harmony of every system in your body, including the nervous system, which controls your blood vessels, your cardiovascular system. Yeah. Things go into disarray without sleep.
How many hours of sleep do you think is optimal for people? Because I know it varies a lot.
Sure. It varies. We're talking about adults now.
Yes.
So I think most people probably need somewhere like 7 to 8 hours. And less, of course, there's always exceptions, but less is usually not enough.
Do you think that it's genetic by any means? Do you think you're kind of born? Because I know I need a lot of sleep. I feel great if I get 9 hours,
sure.
8 or 9. My big brother, his eyes just pop open after 5, and he gets up and his eyes pop open after 5. This is what he does.
Right. So some of it's genetic. I don't know if 5 hours is enough for an individual. Certainly, it's possible for some. Mm-hmm. But the question is, how would he feel if he got 6.5 hours where he's only getting 5? So he may pop up after 5, but the question is, will his memory be as sharp? Will he perform as well? Will he remember, how to execute, how to even just play basketball, play golf, whatever he does? Even procedural memory can change when you get more sleep. So it's not just about can we function okay?
Yeah.
Am I sleepy? But how well am I doing? And how healthy am I going to be?
Right. Yeah. And but see this conversation. Chad, is the air conditioning on, sweetie?
Yes.
Okay. This conversation scares me though, because we all go through periods when you bring home a new baby. For me, like when my mom was sick, or when I was in graduate school, or when you were in medical school, or when you've got a deadline project. We all go through periods where we skimp on sleep, and it's really scary. I almost prefer to keep my head in the sand, because we all you do what you got to do. Don't tell me in medical school you got a solid 7 to 8 every
right,
or when you were doing your residency, or when your children were born, or that kind of thing. Right. So obviously the body can bounce back, but
yes,
this is to be taken seriously.
Yes, but it's like all life habits. Sometimes we don't eat as well as we should,
right?
And so on, and we try to improve it for the long term.
Now let's jump right into the main topic, which is obstructive sleep apnea, OSA. Just define sleep apnea, because I think that there's a lot of misinformation about exactly what it is, and if you snore, does it mean those kind of questions. So what is sleep apnea, OSA?
Okay, so let's think of a simple analogy. So the throat is a nice pipe during the day.
Okay.
It's nice and stable.
It's upright. Yeah.
Exactly. We have muscle tone during the day.
Okay.
When we sleep, the muscle tone greatly diminishes. And so the throat now changes almost to think of it like a fire hose, a hose that's connected to a fire truck that has no water in it. So it's a collapsible hose now. It's no longer a nice open solid pipe.
And that's partly because we go into this kind of semi-unconscious state almost of sleep, or we're so relaxed, and because we're lying down, yes?
Absolutely. So it's position, it's muscle tone, and so the throat is not as stable, and therefore, if you're starting out now with a very small throat, which is what happens to people with sleep apnea, they have a small area of the throat.
Okay.
It's actually more likely to collapse during sleep.
Okay.
So that's the concept of what happens. Now, what is snoring? Snoring happens when air tries to flow quickly through this floppy tube called the throat.
Oh, okay.
And so it vibrates everything. It vibrates the palate and it vibrates the walls of the throat. And that's the sound that you hear of snoring.
Okay, let's go back to sleep apnea for a second. So sleep apnea, you define it though, isn't it? If someone said define it, isn't it when you stop breathing, and isn't it at least 5 times per hour for at least 10 seconds? When they do sleep studies, isn't that what they're looking for? At least 5 pauses per hour, each pause at least 10 seconds. Is that what it is?
So yeah, sure. That's like a textbook definition.
Okay.
But basically, the better way to think of it is that there are multiple times an hour where the throat narrows enough so that air does not flow well through the throat.
Okay.
And as a result of that, most of the time oxygen will drop. And every time that happens, obviously there's going to be a response. So the throat will reactivate, reopen, usually with a snore.
Okay.
And very often an arousal will happen. You'll have a brief kind of awakening from sleep when that happens.
Because your brain is literally deprived of oxygen, so your brain's trying to protect you, correct? So it wakes you up.
It's a protective mechanism.
Now, are you a doctor? Different doctors. Are you a doctor who adheres to this? You must stop breathing at least 5 times per hour for at least 10 seconds. Because full disclosure, and I told you this before we decided to do this interview, and you kind of didn't want to talk about it, but I said, let's just go ahead and get it off. Let's just talk about it. Over the years, I've interviewed 2 other sleep specialists. And the last time I interviewed the one guy, I suppose it was 2015 perhaps. So it was a little while ago. Yeah, I think it was in 2015. So it's been several years. But at the time, upper airway resistance syndrome, UARS, was a thing. Because what it was like if I went in to do a sleep study and I didn't stop breathing 5 times for 10 seconds for 10 seconds, but rather I stopped breathing 6 times for 5 seconds or 4 times for 10 seconds, or it didn't fit the pretty criteria of 5 times for 10 seconds, doctors would send them away and say, you don't have obstructive sleep apnea. But something's wrong. So because in other words, all of health is on a spectrum. Would you not agree? Mental health is on a spectrum. Physical health is on a spectrum. Would you not agree that this sleep medicine is also on a spectrum? You don't either just have sleep apnea or you don't, correct?
Correct. It's definitely a spectrum, and those definitions are a little arbitrary. They're based on science, but they're not rigid. So what's 10 seconds? 10 seconds is just an estimation of 2 breaths. That's all it means. So, but your 2 breaths may be different from my 2 breaths,
right,
in terms of the duration of time. And 5 is just a number where somebody says, okay, this appears to be good enough. Unfortunately, those are the rigid criteria which are used by insurance companies and Medicare to either classify somebody as having or not having sleep apnea.
But because of that rigid criteria that insurance companies use, not necessarily you guys, the doctors, is that why upper airway resistance syndrome, UARS, came to be? Because doctors wanted to be able to do something with these patients and say, okay, look, maybe she doesn't, on this sleep study, maybe she doesn't have sleep apnea. Maybe she doesn't have 5 pauses for 10 seconds, but she's got 3 pauses for 9 seconds, and it's enough to really disrupt her life. Why is this so highly controversial, in other words?
So it depends. That's a function of the history. So what happened initially is that the criteria that were used to classify sleep apnea were more rigid. So many people were not getting classified as having sleep apnea. In very recent years, the criteria became a lot more permissive. You can now classify so many more people with sleep apnea. So now there's a little bit less of this interest in upper airway resistance because most doctors feel that depending on how you define apneas and what's called hypopneas, which are partial obstructions, you can classify most people
as sleep
apnea. And if they don't get it in the first sleep test, sometimes you repeat it and boom, you got it in the second sleep study. So that's why it's less of a hot topic in that sense. But there's also a different school of thought. So, there's Dr. Gil Minot out of Stanford, who's one of the pioneers of sleep and sleep apnea. And he thinks of upper airway resistance as being a very different disease, meaning that these are people who are hypersensitive to abnormal breathing. It's breathing that's sometimes with snoring, sometimes without snoring.
Okay.
But their nervous system responds in an exaggerated way to these small abnormalities in breathing during sleep.
Okay.
And so he thinks it's a very different type of person.
But doesn't it present exactly like obstructive sleep apnea, just not at the same criteria?
It's a little different. I mean, these are people who usually have more fatigue. They may have lower blood pressure. They may have more anxiety, more depression. They're usually thinner, smaller facial bones. They may have more reflux, more irritable bowel, depression, insomnia. So it may be a different sort of in his expert opinion, he thinks of this as being a different kind of problem.
Who treats those people, though? Would they go to somebody like you?
So they would go to any sleep doctor that's would like to help them.
Okay.
But it's complicated because it's not very easy to help someone with these symptoms.
Really?
Yeah.
Because, wow, then things have changed. Because, like, back in the day, like I said, back in the day, these people presented almost identically to the people with obstructive sleep apnea, albeit not meeting the exact criteria.
Right.
So that's fascinating to me.
Yeah. So it's still, some people think it's still like a milder version of in the spectrum, and some people say, no, it's a very different.
Oh, so right now in the medical community, there's controversy in the medical community.
Correct.
Okay, got it. Let's talk about signs and symptoms. We know that, so loud snoring, which is usually, it's prominent in obstructive sleep apnea. Is snoring always present with sleep apnea? So no, this is, and we'll get into snoring in a second, but what I got from reading to prepare for this show was that snoring does not necessarily indicate sleep apnea, but snoring doesn't necessarily mean, no. Okay, but if you snore, that now doesn't make any sense, does it or doesn't it? Because if loud snoring is usually present with obstructive sleep apnea. Yeah.
So snoring is, like I said, when you're moving air fast through a floppy tube that's making noise, okay? Like a whoopee cushion. So, but when I think of snoring, I think of it that you are moving air and you're actually able to move air through the throat. The issue is what happens in between the snoring when there's no airflow. If you have these episodes where the airflow becomes less and less and less, and then it's blocked off, then that's sleep apnea. So what
would it sound like? It would be like, it would be a snore, 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 and then pause, and then snort?
Yeah, so it'll be, exactly. So it'll be like, and then there's a break from this, there's an opening of the airway.
Okay, so it's snore, 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 pause, snore, 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 silence, like that. That's sleep apnea.
Yes, as opposed to just snoring that's more regular and more continuous.
Wow.
Yeah. So snoring it's very rare. It's very uncommon to have sleep apnea without snoring.
That's what I was going to say.
But having snoring doesn't mean you have sleep apnea.
Okay, but if you have sleep apnea, do you probably snore? Yes.
Oh, most definitely. Yes.
Do you ever see anybody who doesn't snore who has sleep apnea?
Yeah, for obstructive sleep apnea, it's pretty uncommon because you don't just go from breathing normally to not breathing. It's more common to have the intermediate, which is making noise while breathing.
Okay, so let me say that. People who have sleep apnea almost always snore, but people who snore don't necessarily have sleep apnea. Is that accurate? Did that make sense, Chad? Did that make sense? Yeah. Okay, so people who snore don't necessarily have sleep apnea, but people who have sleep apnea, you'll almost always find them snoring in their sleep study. Golly, that's interesting. Okay, so again, loud snoring, which is usually episodes of breathing and then cessation, like we said, abrupt awakenings accompanied by shortness of breath. But these people still aren't necessarily aware of these little awakenings. It's just kind of like, and then turn over. It's one of those things. They're not even aware of this.
Not aware because you don't have time to form a memory. If you wake up for a few seconds, your brain is not going to register that.
Okay. Also, awakening with a dry mouth or a sore throat.
Sure.
Like if you just wake up. Okay.
Sure, that happens to many people, like a really sore throat. And some people are such bad snorers that they'll have swelling of their palate when they wake up in the morning.
Wow. Yeah. Morning headache. Why morning headache? What is that?
It's a good question. So we don't know exactly, but one of the main reasons could be the oxygen. With being deprived of oxygen during the night can create a morning headache.
difficulty staying asleep. So like, but it's not necessarily insomnia. It's just for some reason you keep tossing and turning. Like it's not because I suffer with insomnia where you're just lying there going, okay, 1 sheep, 2 sheep, 3 sheep. That's like insomnia, but I'm not. It's difficulty staying asleep, meaning you keep waking up and you're like, wait a second, why do I keep waking up? And you think it's because you've got to go to the bathroom. But what really happens is you wake up and then you realize you have to go to the bathroom. You don't wake up because you've got to go to the bathroom, correct? Right.
Both are true, correct, but both are true. So sure, like you said, you wake up multiple times because your sleep is being broken up. It's fragmented.
Yes, okay.
And then you say, yes, I have to go to the bathroom because I woke up. On the other hand, sleep apnea also is associated with having this urinary urge during the night and having to go and void many times.
Isn't it called nocturia? Yeah.
And that might be through a hormone that's released actually in the body. So,
which hormone? That's interesting.
It's not well established, but it's thought that something is released that can mediate that.
Wow. Yeah. Okay, and then of course excessive daytime sleepiness, attention problems, irritability. That all makes sense. Let's talk about the main types of sleep apnea because there are 3 types, but we're mainly talking about obstructive sleep apnea because aren't the majority of cases diagnosed obstructive sleep apnea.
You got it.
Yeah. Okay. So explain obstructive sleep apnea. You say it's the most common form when the throat muscles relax, which you've already told us.
Correct.
Yeah. What is central sleep apnea?
So obstructive is when you're trying to breathe. You're still trying to breathe, but the throat is blocked, so you cannot move air through the throat.
Okay.
Central sleep apnea is actually when your brain is not sending the message to breathe. So you actually so you're not breathing and you're not trying to breathe. So you're taking a pause from breathing.
Okay, so it's when the brain doesn't send proper signals to the muscles to control breathing. Why would that happen?
Right. It happens if you're having a problem in the brain. So, for example, after stroke, that could happen.
Oh.
That's one case.
Okay.
The other mechanisms are when there's a problem with the timing of breathing. The brain doesn't know when to time the breathing with the rest of the functions of the body. So that happens to people with a heart attack, when they have congestive heart failure, or people with atrial fibrillation, where, again, the brain just doesn't know how to time the breathing with the circulatory system.
I know a lot of people with atrial fibrillation, though. But here's the thing. I do know a lot of people with atrial fibrillation, all of whom are obese. That's scary, though. That's scary. This one to me is more scary than obstructive sleep apnea, because obstructive sleep apnea, you change your sleep position. This one's more scary. The brain's not signaling. Do you treat central sleep apnea?
So I do, but less commonly. It's not as common. Sure.
Okay, so you don't find that. Okay, but people who should be looking out for it are people who have had strokes.
Sure.
Who else? People who have had brain injuries,
heart attacks, brain injury. You got it.
Okay.
Mm-hmm. Yeah.
And then mixed or complex sleep apnea, what is that?
So that's where you can have a combination. You can have, if you say mixed, then it could be a combination of obstructive and central, where you're not trying to breathe type of events during the night. So that's, again, pretty uncommon. That's pretty uncommon, but can happen in some people.
You probably don't see that one very much.
No, uncommon. Yeah. I've taken care of those people, but not common.
Now, what I want to get across here is that, all right, so people with obstructive sleep apnea, the frustration has to be if they are in bed 8 hours a night, doing their best, trying to sleep, and they think they're sleeping, and then they awaken, they're not refreshed, they're dragging them around. It's because when the breathing pauses, or when breathing pauses, or when it actually becomes shallow, even if you don't wake up, isn't it true you move from deep sleep into light sleep? And so that essentially is almost the same for the body as not sleeping at all. Is that accurate? So in other words, you never, because what your body really wants is that deep restorative sleep, correct?
Sure.
So you never get a chance to move into deep restorative sleep. That's why you slept for 8 hours. And again, you were sleeping. It was light sleep, but you never get that deep restorative sleep. Is that the reason you just feel so crappy?
Yeah, your sleep is basically broken, meaning that you have this beautiful symphony, but now it's cacophony because You're going into a certain sleep phase, and all of a sudden, because of the obstruction, because of the apnea, you get woken up or aroused. You go into lighter sleep, or you break up your REM sleep. Whatever happens, you destroy the beautiful architecture of sleep by having these repetitive obstructions during the night.
And that deep sleep is the restorative sleep. It's not the light sleep where you're,
Yeah, I mean, deep, well, it's a little misnomer because all sleep is important, of course, but the way we classify it when it comes to deep sleep or REM sleep, yes, there's a very often not a lot of what we call deep sleep with sleep apnea or disruption of REM as well.
Okay.
Another very important phase of sleep.
Now, let's bust this myth, because I don't want people to tune out because they think, well, I'm not a male, I'm not overweight, I'm not, the myth used to be like a lot of myths that like when I was young, that the only people who get this disease, obstructive sleep apnea, are 40, 50-year-old men. They're fat. They've got big fat necks, big fat bellies. That's not the case. And that really screwed around a lot of people because that's what doctors were looking for, correct?
Correct.
So what's the truth? If that's a myth, what's the truth? I've talked to doctors who have seen little skinny women, 30-year-old women with sleep apnea.
Sure. So first of all, the obese middle-aged man came from the fact that sleep apnea was first diagnosed in these super obese people that couldn't stay awake during the day. Okay. They were called the Pickwickian, like the Pickwick Papers book. So that's where the notion came from. But as I said before, the issue is really a small airway. So a small airway can happen when you're obese, because when you're obese, your tongue gets big, actually, very large, the fattest muscle in the body. Second thing that happens is...
Can I tell you something? I've worked a career with obese people. I did not know that your tongue gets fat. I did not know that. I don't look at their tongues.
Yeah.
So when you get obese, when you gain weight, your tongue gets fat?
Your tongue gets fat, yeah. Your tongue, the walls of your throat, and your neck, therefore.
I knew the neck.
Right. And actually what's very, very cool, which I learned from a obesity specialist in Australia when I was presenting at a meeting there, is actually when you lose weight, you lose it first up here, meaning in the upper airway, in your neck, your face. And that's why people say, hey, you look different. What happened?
Oh, yeah. When you lose weight, you lose it from top down.
Right.
Yeah, people, you first see it in the face and the neck. Yeah.
And that's the good news for people who are trying to lose weight to help their snoring or sleep apnea. So let's get back. I'll get back to the question. So the airway has to be small. So it can be small due to soft tissue if you gain weight. It can also be small due to the bone structure. And this is, again, what we're talking about. People with small upper jaws and lower jaws. Unfortunately, for example, there are a lot of kids that had orthodontia. They had their braces, and for their braces, they were told, yes, your mouth is so small, your teeth are crowded, so we have to remove your 4 premolars, your 4 bicuspid teeth for the braces. Yeah. And by actually removing those teeth, the jaws even became smaller. So that was...
Wait, is that practice still done? I didn't have braces, so I don't know.
Right. So less often now, but occasionally still being done, which is not good. Obviously the better way to do it is to say, hey, your jaws are small, let's put an expander and make them bigger, and this way the teeth will have room to grow properly and fit. People are born with small jaws, and sometimes, occasionally, that could also happen.
When you say jaw, you mean the bottom jaw or the top? Which are you mean?
Both, and I actually look more at the upper jaw, the maxilla, because that's where we see the most narrowing when it comes to sleep apnea.
Yeah.
So it can be narrowed in width, and it can also be narrowed front to back. So there's different ways to look at the jaws. But
you're making me wonder. I don't mean to interrupt you, but I'm scared I'm going to forget. You're making me wonder, why don't little tiny children have this problem?
But they do. They do.
So because little tiny kids, think how little, in babies, children and babies.
Right. Great question. So.
But that's scary to me. That they're suffering. What do you a little baby? Talk about tiny.
Sure. So here's the beauty. The beauty is they have amazing tone. So babies, toddlers, kids have great muscle tone. So that muscle tone keeps the throat stable even though it's small.
Okay, so little kids are immune to this mostly, unless
they have big tonsils and adenoids. And that's the number one, factor for sleep apnea in children, because children also have sleep apnea.
Okay. Yeah. All right. So again, let's bust that myth. I could have sleep apnea. Chad, any male, female, small, big, obese, tiny, anybody could have sleep apnea. And what do hormones have to do with sleep? Because I know that, like I said, I talked to this one doctor. He had a lot of thin women in his practice that had sleep apnea. Again, would that go back to the physical size of the throat and the airway?
Definitely, that's one factor. So the overall size of the throat. Mm-hmm. The other is something that we don't have a good way to measure right now in people who come to see us in the office, in the clinic, is muscle tone. So we all have different degrees of muscle tone and muscle control. Uh-huh. So if you have great muscle tone, then in the throat, then you may have less probability of sleep apnea, collapsing the throat during sleep, as opposed to someone else.
But what do hormones have to do with sleep? Meaning, does this also pull women in because of what is that? What's going on?
Yeah. So, for example, one hormone is progesterone.
Yes.
Progesterone, in some research, has been shown to actually stabilize the upper airway. It's able to keep things more, from collapsing. And
okay.
Yeah, and that's why we think that could be one of the reasons why women, with post-menopause, actually all of a sudden the incidence of sleep apnea shoots to the roof.
Well, I'm not a gynecologist and I haven't talked to one in a long time, but isn't it true that when a woman is going through menopause, first progesterone takes a nosedive, then estrogen starts to nosedive? Is that accurate or am I dreaming that?
Don't quote me.
What?
No, I don't even recall the order of decline.
Okay, but progesterone. Yes. But progesterone does decline in a menopausal woman.
Yeah, I mean, there's basically the release of hormones becomes unstable. When you're perimenopausal, and with eventual decline, certainly, and that's that gives rise to a lot of the symptoms that come with menopause and the disturbed sleep, because these hormones also have an effect on stabilizing sleep.
Oh, that's why a lot of menopausal women say, "I can't sleep." Right? They say that, right?
Insomnia. You got it. Yeah. Mm-hmm.
Hey, we got a question.
Yes, baby.
If you don't mind me jumping in, from Jason Campbell.
Yes.
He writes us, technology has advanced to the point where it can help clinicians deliver more personalized care.
Oh, that's a question?
No, here's the rest of the question.
Okay.
I just had to clear my throat. Forgive me. Wearables such as Apple Watch, Fitbit, etc., are supposedly able to detect serious conditions such as sleep apnea. Do you recommend purchasing Fitbits and Apple Watches for that purpose?
Is that accurate? I did not know that. I didn't know that Fitbit helps. So Jason's saying that Fitbits and Apple Watch can help.
Yeah, they track your sleep, or are at least they claim to track your sleep.
What is that, Doc? What do you think?
So I think they will. I'm not sure that they're accurately doing that now, meaning that they're doing it within a certain percentage. They may underestimate your sleep, let's say by 40 minutes. By a factor of so and so, they may have about 40 minutes to an hour. They may miss the mark. So they're not true sleep markers. They are actually checking more activity, motion, rather than they're not measuring sleep.
They're detecting motion, heart rate, things like that, not deep sleep. Right. They can't tell what's going on in the okay.
But the future is very bright. So now the future, which is already here in some ways, is being able to measure oxygen through your skin. So then one may
oxygen. They can. I was at the doctor the other day. Sure. They measured my oxygen saturation by putting a clamp on my finger.
But now even these watch wrist-like devices may be able to do it even without having something on your finger. Just think about comfortable, sleeping comfortably.
Have you ever been approached by what did Jason say? Fitbit, Apple Watch. Have you ever been approached by one of these companies to perhaps, because you just said they're good, but they're not great. Like the purpose of an Apple Watch is not to monitor for sleep apnea. Okay, right. For a Fitbit to monitor for sleep apnea. So they're not necessarily 100% accurate. Just like I tell clients, when you walk on the treadmill and it says you burned 854 calories, don't believe it. Because it's not, it's just, you know what I'm saying? It's guesstimating, but it's not. Have you ever been approached by one of these companies because it sounds like that's almost the wave of the future, to get everything you need in your Apple Watch?
Right. No, I have not been approached by companies specifically for these devices, but obviously I'm in contact with many, and I have been in contact actually with a company that has a very easy to use, easy to sleep with type of home sleep apnea test. The company is called Itamar Medical, and they make something called a watch pat, which is almost just like wearing a large watch on your wrist.
Okay.
For sleep apnea during sleep, without.
Well, I'm glad you brought that up, because this kind of continues in the vein of Jason's question, and thank you, Jason. But and Chad, let us know if you have any other questions. That's great. It used to be, if you wanted to know if you had sleep apnea, you had to go to one of those horrible sleep studies, which I could tell you, it would be a disaster for me. Don't they like put electrodes all over you and make you sleep in a funny? Now, though, you said in your notes you can do a lot of that at home. Do you trust that 100%, or do you trust it as much as a sleep study, a formal sleep study?
So I do, but I look at the data. You have to look at the data and make sure you like the quality of the data. So I do trust it because, like you said, you're sleeping in your own bed. It's comfortable. You sleep in the normal sleep position, and your sleep should be a little more closer to normal. So I do trust it, as long as obviously it makes sense, as long as the data looks good. But again, if there's a question, either based on what you told me after you used it last night, yes, I had this problem, that problem, and I look at the data and so on, then obviously one can either repeat it or get a comprehensive test in a sleep lab if there's any problem.
What goes on in a sleep
lab? It's very uncommon.
In a sleep lab, do they make you sleep in a certain position because you have electrodes attached? Yeah. See, that's why I would fail miserably.
So you would, but some people, that's why you think about sleep apnea. Some people with sleep apnea, they're so tired that even though they have electrodes on their head, they have a cannula in their nostril, they're wearing like belts on their legs and belts on their abdomen and sensors on the fingers and all that, they'll still with all that and sleeping on their back, they'll still fall asleep.
They make you sleep on your back for a sleep lab test.
So the technicians usually instruct that to the patients. Although when I use a sleep lab, I tell the technicians, please have the patient sleep in their normal position. But they make it's preferred in the sleep lab because this way, the wires, things don't get crossed, things don't get, tangled or detached. So
no, I got that.
Just for the equipment side, but it's obviously may not be normal. In fact, I've had some people come in with sleep studies from a sleep lab, and I looked at that test and I said, horrible. Okay, you got a bad case, but do you really sleep on your back? Because it said that he slept on his back the whole time. And he says, no, I don't sleep on my back. And guess what? This person told me, no, I feel fine. So I said, we're going to do a test at home and let's see if you have sleep apnea. Okay. And there were a few cases where I said, you don't have sleep apnea. I think there was an artifact, as we say.
Where would somebody, let's say this Jason who asked the question, this thing that you're saying you can do at home,
right?
You said it. You almost like is that something that somebody like Jason or someone else could just go get, or do you have to get it through prescription through a doctor?
Right. So right now you'd get through a sleep doctor like myself or a sleep lab.
You get a prescription for it. Okay.
No, actually, I have those devices in my office, and if somebody needs a sleep study, I can authorize it through the insurance, and then you do it at home that night.
And what is it? What is it?
Right.
It's a watt. What is it exactly?
So it has three parts. It has one part that's like a little disc that you stick just at the base of your neck, and what it is basically a position and a snoring sensor.
Okay.
It's attached with a little wire to the large watch, if you think of it, on your wrist. Again, it's called a watch pat, if you're curious. And then it also has one of these finger sensors.
Okay, that's cool.
Now, the watch, like your Fitbit, records, tracks movement.
Okay.
And also, in the finger, it doesn't just measure your oxygen. It also measures what's going on within your blood vessels, meaning what is the tone of your blood vessels. Why?
Wow. Oh, I know why. Because during an apnea, they collapse.
Exactly. They contract. The nervous system clamps them down.
Okay.
And we can see that. And there's a beautiful charts, that come out on the data stream, and you can see that happening at the same time that the oxygen is dropping.
Okay, and that's why people with sleep apnea have high blood pressure, correct? Because during their apneas, the blood vessels clamp down. Yes. Yeah.
So it all goes along. It all goes along. Yeah. It's just
so if someone like Jason wanted it, he just goes to a sleep doctor and says, "Hey, do you have that? What is it called?"
So this test is called the Watch PAT, P-A-T.
Watch
PAT.
P-A-T.
Yeah.
Okay.
Yeah. That's my preferred home sleep test because it's the easiest to use. Very hard to have a problem with something detaching or
how long has it been on the market? Just out of curiosity.
So years. I mean, definitely over a decade.
Wow.
Over a decade. But it's again, you asked, do a test at home? Is it as good as a test in the lab?
Mm-hmm.
It's only as easy as it is to apply. And the other question is, do you have a problem with losing data at home because you don't have a technician to fix a problem?
Mm-hmm.
Well, when you have a simple device, it's easy to use and very hard to mess up the tests. Then the quality of the data is very good, and the rate of bad studies is very, very low. So
now, a lot of people have a deviated septum. I did too. Did you ever have a deviated? I think all little kids, like when I was a little kid, about 5 years old, I went to run and jump to grab a monkey bar, and instead I smashed my nose into the monkey bar. Nothing was done. But when I was about 23, 24, I was having breathing problems, and so a doctor went in and he didn't alter my nose, but he altered internally, just fixed the septum. Does a deviated septum almost guarantee sleep apnea, or does it factor in at all? Because a lot of people have a deviated septum.
Sure. So it doesn't guarantee having sleep apnea, but not breathing through the nose is a big problem, and it makes you much more likely to have sleep apnea if you have a nasal blockage issue.
Okay. So if breathing through the nose, especially when you're sleeping, can be because then you're a mouth breather.
Right. So breathing through the nose is beautiful breathing. I mean, think about it. Every Eastern art, yoga, meditation, martial arts, they all teach you the same thing. Breathe through the nose. Because if you breathe through the nose, you have what's called laminar flow. You have this smooth, beautiful airflow from the tip of your nose to the bottom of your lungs. When you are mouth breathing, the airflow is very turbulent. It's not stable, nice breathing, especially during sleep. In fact, sure, if you're a runner, you're going to open your mouth to some degree sometimes when you need a little extra boost of air. But during sleep, breathing through the nose is almost effortless if your nose is open.
Right.
Breathing through the mouth is work, actually. So there's a huge work in breathing through the mouth because the throat actually gets smaller, gets narrower when we open the mouth. And that's a good reason why certainly having having a blocked nose would contribute to snoring and possibly sleep apnea.
And by blocked nose, so having a blocked nose would contribute to snoring and sleep apnea. Having a blocked nose would come from a deviated septum. What else?
Sure. So anything that irritates the nose. That could be smoke, allergies.
Oh, like inflamed.
Sure.
Inflamed.
Right. Will cause swelling,
Oh, so swollen nasal passages.
Polyps people can have.
Nasal polyp. Okay,
right?
Okay.
The septum is obviously fixed, right? It's the cartilage and bone in the middle of the nose, and that can cause narrowing of the nose. And also, some people have something called collapsible nasal valves. So think of the sidewalls of your nose.
Okay.
And if we all sniff really, really fast, we can make them collapse.
Yes.
But some people have a problem with that, and those are the people that either wear little stents in the nose or the breathe right strips on the outside of the nose to keep the nose open, because otherwise the nose would collapse too much when they breathe in.
Well, and if and you have medical treatments, I don't want to spend too much time on this because I want to get to the obstructive sleep apnea remedies. But I just want to say you have medical treatments, obviously, if you've got nasal blockage or sinusitis, to get the swelling down, that are geared at getting the swelling down. A lot of it has to do with being aware of allergens. Yeah. But if medical treatments aren't enough, you have turbinate reduction. You can go in. What does that consist of? These
turbinates look like little fingers that are sitting in the bottom of your nose, and they tend to swell a lot.
Okay.
During the day, when you're lying down, from allergies, you name it. So there's a way under local anesthesia to just numb them, and then one can use a small instrument that pokes into the turbinate and thins them from the inside out while preserving the lining of the turbinates to keep their function, but
So
they become skinnier.
Bringing them, Turbinate Reduction.
So
what is it? Vivair? How do you pronounce it?
So Vivair.
Vivair?
Vivair is a brand new procedure from Aerin Medical. That's Aerin. 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 Medical.com. And this is an amazing procedure. I was their principal investigator in a clinical trial. So this is for people who have this collapse of the nose on the side walls, where the breathe right strips. And so for those people, actually, what one can do is just numb that area inside the nose. Mm-hmm. And we use this little wand, this little probe that I place in the nose, lifting up that area of the nose that's collapsing.
Okay.
And under local anesthesia, one just heats it. One warms it to about 60 degrees centigrade. And when you do that, it can actually modify that area. It changes it so it becomes a little bit more open, a little bit more stable.
And that, Vivair,
right.
And balloon sinuplasty.
And by the way, and this is without surgery, because normally to treat that, you need major surgery. So this is
all in-office procedures.
In the office, yeah.
Yeah. Balloon sinuplasty.
So balloon sinuplasty is like angioplasty for your sinuses. So the idea is if your sinuses are blocked, the passageways are blocked, for many people, one can create a wider passageways from the sinuses into the nose just by placing this banana-shaped balloon into the area and inflating it. It's a rigid balloon, so it just opens it up.
But a lot of it has to do, if you have inflamed internal sinus passages, a lot of that has to do with allergens, and I think.
Sure.
But, And one of the things I do, and you even mentioned this, and I do this religiously, because I have ear issues. Which are ear, nose, throat. It's all the same, I use pressurized, like saline, like simply saline.
Great.
Not the little, just the one that you squeeze in the soft bottle, but the high pressure. What is that? That's not aerosol, is it? No, it's not. It's like a it's pressurized saline.
Yeah, it's pressurized.
And I use it like when I get up in the morning, wash my face, brush my teeth. I use that. And it's kind of like and then you just get all your snot out, and then obviously coming home after being in New York City when, it's dirty. We have dirty air here. Again, nighttime, wash your face, brush your teeth, wash out. If I'm home in the middle of the day, I'll do it a third time. I literally use saline to clean my sinuses out.
Yeah, and that's great.
Okay, and that's really helped me. And again, not the one in the little soft squeeze bottle, but the pressurized can. The brand is simply saline, or you can get the store brand. Do you agree with that?
Sure, yeah. I mean, it helps wash away the allergens and things that are not allergenic but still irritate.
Dust, and things like that. Yeah. I want to say this. Okay, so you said if you do snore, you don't necessarily have sleep apnea, but I would like people to be able to, kind of get a handle, because if you're not sleeping in bed with someone else, it's hard to know what your snoring pattern is. You recommend an app called Snore Lab?
Right. So that's an app that you get on any smartphone platform, and you can record the sounds of your snoring, the sounds of sleep. Let's put it this way. And then in the morning, you can actually look at those peaks on the graph. And when you touch the peaks, you can actually listen to the snoring sound itself. So you can convince yourself, even though you may deny it otherwise, that you are snoring.
Okay. And what you can do with that then is you can hear if you are consistently snoring, or like you said, or if you have a break, a break and then a snort, like
right.
Like, okay, so Snore Lab.
Yeah, like a laboratory.
So Snore Lab, if people go to the App Store, Snore, is it Android and iOS? Okay, Snore Lab, you guys, Snore Lab. Chad, that sounds good, eh? Snore Lab. Would you be inclined to use something
I'm going to
like
look
that?
it up on my
Samsung. Snore Lab. Yeah, he's got an Android.
I mean, there's more apps, but that's just one example. So,
okay, Snore Lab. Yeah. Now, do you have a problem with snoring? If the person doesn't have sleep apnea, do you have an issue with snoring? If someone doesn't, I mean, do you care? I mean, other than irritating people, is it harmful to the body?
Right. We don't know. That's the answer. We don't really know. Some doctors will say no because it's not sleep apnea, so you're not at risk for all those things we discussed, like cardiovascular issues. But There's some research that says, snoring, think about what is snoring. Snoring is mechanical vibrations, right, in the walls of your throat.
Okay.
And there are some studies that show that they may cause injury to your carotid arteries, which are in your neck, depending on the severity of the snoring. And there's studies that show increased plaque in the arteries in your neck with
just from snoring.
With greater snoring. But
they've correlated the snoring to the plaque.
Yes. So there are some things like, and this is an area that needs more study. But what I'm saying is that, like everything in medicine and especially in sleep, we have a long way to go. There's a lot to learn. But currently, we say if it's just plain snoring, it's not disruptive, it's probably okay. But some of us are saying, I don't know. And if you think about it another way, right, we're all about health and wellness. Mm-hmm. So I don't want to treat you when you have full-blown sleep apnea. I'd rather treat your airway and make it better before it's full-blown while you're in an early phase and prevent you from going there.
Do I hear you saying that people who snore, who don't yet have sleep apnea, possibly are on their way to it? Is that what
it could happen? Again, not for everyone, obviously, but snoring may evolve. As I said, snoring is trauma, right? It's mechanical vibration. And there is some research that shows that with heavy snoring, you can actually damage the sensors in your palate and in your throat, and then you become, you actually create neurological damage to your throat, so it doesn't respond normally to the signals in sleep.
And again, if someone is using something like the Snore Lab, the app, the Snore Lab, and they are monitoring they're listening to their own snoring, what they're listening for is if it's just consistent snoring versus if it's snoring, silence, and then some more snoring. That's the main thing that they need to be on the lookout for, correct?
Right. So that's a clue. I mean, obviously, it's not foolproof. That's why you need to put it in context.
Okay.
But at first, just convince yourself you're snoring, and again, if you pick up that pattern, it's a lot more convincing.
Okay.
Yeah.
And how do you treat snoring? I know that you gave me some pretty obvious things that stop smoking.
Right. Avoid the irritants. Stop smoking. Treat the allergies. Definitely.
Yeah.
Alcohol is good in moderation, but guess what? It has a direct effect on muscle tone. So you're going to snore. That's why people, when they have their alcoholic, they go out, they have some alcohol, they come back home, and the snoring symphony begins. So so limit alcohol, have it earlier in the evening. If you like to have some wine and so on, have it earlier so it has a chance to metabolize. So those are simple things.
Make sure the nose is open, meaning, because I snore when I have like sinus stuffiness. If I got a cold, forget it. That's pretty typical, no? Yeah?
Sure, of course.
Yeah. Okay, so make sure that the nose is open. That would be all the things we talked about. The saline spray, again, I use that religiously. You say avoid sleeping on your back.
Right. When you sleep on your back, the airway actually gets smaller. The tongue also may fall back. So sleeping on the back is notorious. I mean, most couples know that. You sleep on your back, the snoring, you get the black and blue from the elbow jab and on side. So not sleeping on the back may help, and there's ways to do that. It's not just I'll try not to sleep on my back. So,
I like to say I'm a side sleeper. Right. I don't know anybody who sleeps on their back, but I tell you this: when you're in the hospital, they make you sleep on your back. And it's I've never spent the night in the hospital. But I've had relatives who've had to. And it's exhausting because you don't get good rest when you're in the hospital. They make you sleep on your back, no?
It's more of like you said, a natural hospital position, but
the bed's partially propped up.
That helps a little bit, by the way. So one of the things, that's why they sell all these, they make these claims on some of the beds in the market that you have a snoring treatment of snoring position by elevating the head of the bed. That's really what you're talking about. So when you move the head of the bed higher, you're actually getting some.
Well, then you're
right.
Yeah, you're not going to collapse on your
Right. One thing is what happens to the tissues of your throat. The other is you're getting also more atmospheric pressure. So you get more of the column of air above you, stabilizing the throat. So
I just sleep on my side.
Yeah,
I just sleep on my side. Theravent. What is Theravent?
Theravent is a really cool idea. It's basically putting a little Band-Aid on your nostrils, basically under your nose, covering your nostrils. The Band-Aid has a one-way valve. So when you breathe in, the valve is open and you're breathing in. When you breathe out, the valve partially closes. So what happens then is a little pressure develops in your nose, and then that pressure also travels backwards and stabilizes the area behind your palate. So you're creating some natural pressure in your nose and throat.
You put the Band-Aid like right there?
Yeah, right above your
right there,
your upper lip, and cover your nostrils. You cover your nostrils with it.
Wait, then how do you get air into your nostrils? That's where I'm leaving.
Because it's not a Band-Aid. It has, in the center of it, it has this valve. And the valve is open for breathing in, and it's partially closed when you breathe out. So you can breathe, but it creates a little back pressure when you exhale.
Where do you get those? Like, you get that via prescription from someone like you, from a doctor?
No, actually, this is marketed for snoring. You can get it at most drugstores or order it online. Correct.
Okay, TheraVent, THERA vent, TheraVent. I've never heard of that.
So
TheraVent.
So that can work. The problem is, of course, like everything, like you just as we were talking about, the question is, are you going to like it?
I'm not going to like it. I'm not doing it.
Right?
Yeah.
And some people may open their mouth too much, perhaps, and so but it's definitely, it's hit or miss, but it can work for some people.
Okay, and also for some snoring situations, you have to do oral appliances. Is that one that fixes the jaws? Does it pull the jaw forward? Like, what do these oral appliances
do? Exactly what they do. They keep they move the jaw forward. They keep the lower jaw in a forward position, a more forward position usually.
So what is it, like, goes on the teeth? It goes in what does it do?
Right. So it's something you wear on your teeth, and by keeping the jaw, by wearing an appliance, two things can happen. One is that you may actually close your mouth more during sleep.
Okay.
And that can also help, as we said. The second is that by moving the jaw forward, you're actually putting a little traction on the walls of the throat. By putting traction on it, they become more stable. So it's by...
Does it hurt, though, to have your jaw pulled forward?
No, it doesn't hurt. And certainly you don't want to do it in an uncomfortable position. But not everybody likes it. You have to get used to it in a certain way of wearing something in your mouth on your teeth. So there are people who like it, and there are people who don't like it. And there are people who get used to it and people who don't get used to it. So,
And finally, palate procedures in the office. So if someone is really snoring and none of these other things apply, you can do procedures on the palate.
Right. So you could do procedures on the local anesthesia. What I tell my patients is that snoring is really hard to treat. And sometimes you need more than one way. But certainly if let's say you tried sleeping on the side, you've tried X, Y, and Z, and you still have a need, then palate procedures can be a good idea. The palate can be stiffened. In other words, you can put little fibers into the palate or use radio frequency to make the palate a little stiffer so it vibrates less. And the other thing you can do on the local anesthesia is modify the palate. One can actually make small cuts. There are very specialized instruments that I have that I can use to make the palate a little shorter or open it up a little bit on the side. Sometimes the palate is like webbed, meaning it looks like a curtain that's almost closed. So you can open up the curtains.
And these are procedures that you do at one time and you're done.
Typically, I do it at one time, correct? And obviously, we make sure everything else is working. So you got to keep the nose open. You got to help the person not sleep on the side.
Right, but one and done. Like you get it done and then you're done. It's not an ongoing thing.
Correct. Although if somebody says it didn't work good enough, then we're looking for additional ways to help them, medical or with procedures, obviously, to see what else is the problem that can be. So we try to do everything. Myself and my colleagues try to do everything, obviously, in one sitting for the patient.
Now let's talk about obstructive sleep apnea.
Sure.
All right. So what scares me is, I think what I read was 22 million Americans have sleep apnea, and there's about 80%. What did I read? There are a lot of people who don't know they have it. So that's what troubles me the most. Just like there are a lot of people who don't know they have type 2 diabetes. There are a lot of people who don't know they have high blood pressure. There are all these silent things that are killing us. So but it's really easy. It's fairly easy to treat once you know that you have it. But let's talk. So treatments. Number one, weight loss. Easy peasy. It's not that it's easy to lose weight, but it's the most natural way of solving the problem. Correct?
Correct. So maybe about 10% of body weight is a good target for sleep apnea. we think. So obviously there's no perfect treatment, but we have to just find a treatment that's going to work for you. You're the patient. So what's going to work for you? And that's the secret, I think, to treatment. Personalize it, find a treatment that's appropriate for the individual. So for some people, they'll get motivated. They'll say, okay, I can do it. I can lose that weight.
But also, I've worked with clients who are hundreds of pounds overweight. I mean, like they could stand to lose 200, 250. If they were at least... I would say at least get yourself to an ideal weight before you start thinking about any surgical options. Always do the best you can on your own without, sometimes just losing weight and getting rid of a thick neck and, will really help.
Sure.
And so also air pressure, the CPAP machine. I've been wanting to talk to you about that.
Sure.
CPAP stands for continuous positive air pressure.
Yes.
Yeah. Back in the day, like let's say 20 years ago, right? They were a disaster. I mean, they were these big, they looked like gas masks. I mean, I would see people, I don't know how they slept. I couldn't sleep with a big mask on my face. But I had a client, and this was several years ago, so I'm sure they've gotten even better, where it was just two little cannulas that went up into his nostrils.
Right.
What's going on right now? Because I've seen the gas mask and I've seen the two cannulas. The two cannulas looked very manageable.
Yeah.
But he still hated using it. He did not have a good compliance rate.
Right.
So what's the deal with these masks?
No, so exactly. We used to have these Darth Vader masks and working and portable air conditioners size, but now actually the devices everything's miniaturized. And it's a huge market. So think about how much money is invested into making this comfortable. So now, like you said, there are some very small, soft things you can wear under your nose.
Just the little cannula.
With very comfortable tubing that actually becomes the strap at the same time. The tubing is actually the strap across your cheeks at the same time. And so these, so for many people, this can be a comfortable way to treat their sleep apnea. Of course, it's all about human nature. So some people will still say, "No, I don't want to use a machine. I don't want to travel with it.
Well, if you've got the one,
I have to clean it."
You do it right, but the one with the two little cannulas that go up into the nostril.
Yeah.
What is because you said in the article, you gave me an article that you wrote in a magazine that I believe was written for other physicians, correct?
Yes.
Yeah. Because, that you only get like about a 50% compliance rate, even though they're getting very...
Sure. So it's human nature, right? It's human nature. Like you said, you have a friend who says, yes, I use it, but I don't like it. So it's very hard. There are people who will use it and they'll say, I can't sleep without it. I'm religious about it. It's so good.
Okay.
And there are people who say, yes, I'm using it, but doctor, what else do you have? I know it's good for me. Yeah, so it depends. You have to fit the treatment with the person. Sometimes you tell them, look, I know it's not the best thing that in terms of on your wish list, but you're doing pretty well. And so keep going, and we'll keep an eye open because it's a new field and we'll have new things for you before you know it.
What does it consist of, though? Okay, so you've got the two cannulas in your nose and then a little strap.
So I'm describing something where you're wearing something soft, like a cushion. We call it cushions or so on, or pillows under your nose to fit into your nostrils.
Okay.
And then the particular mask I'm describing has also these are connected through this soft tubing that just adjusts to your face.
It goes over your ears.
The contours of your face comes out the back. And then there's a small hose that connects it to a machine.
Okay, that's my question. This is why people don't like it, all right? Okay, so here's the deal. I wouldn't mind having a little tiny thin thing and a little something. No big deal. But now I've got a hose to worry about. Yeah. All right. Answer this just for practicality. I sleep on my side, like in the fetal, like I curl up and then I'll turn over and I'll roll over and I'll do it. Would I awaken like wrapped in a hose? Like, do you understand? Like I could wake up seriously, completely wrapped with a hose wrapped around me, unable to escape my own bed. Seriously. Like what do you do if you toss and you turn? Honestly, I wouldn't.
That's a good question.
Yeah.
Yeah. No, so obviously there's a lot of design that went into this, and now everything obviously has swivel joints, and there's all kinds of
so you can roll over.
Yeah, people can roll over. Yeah. So there's so much money into this business that that's been taken care of, I believe, for most people. And the machines are also smart now, so they're not just delivering a continuous air pressure. The machines now sense, so they can give you a little bit more air pressure on the night where you had some alcohol, a little less pressure when you haven't, or when you're sleeping on your back, you're turned on your back, they'll give you a little bit more pressure, a little less pressure. Or if you lost weight, they'll give you gain weight.
So tell me this: how does it work, though? How does having the continuous air keep me from snoring? I don't understand.
Right. So it's all about air pressure. So think again about the hose, right? The hose that doesn't have from the fire truck that doesn't have water in it. Now, if you pass a little bit of water through it, it's going to flutter, right? It's going to vibrate.
Okay.
But what if you now turn on the water pressure? You got nice, strong pressure going through it. You just have, again, a solid pipe where everything just flows through. So air pressure stabilizes the throat from the inside out. It just blows up the balloon.
So these people stop snoring? Yes?
Correct. I told the patient today, he came in with severe sleep apnea. I said, when you start using the machine, the first night you use it, you're not going to be snoring as long as you're not leaking from the mask or something. You won't be snoring.
Okay. So so it literally can stop snoring.
Yeah.
Okay.
Yeah.
And also positioning, by that you mean sleep position, I imagine, correct?
Yes.
Here's the deal. I might even have sleep apnea. Who the heck knows?
Right.
But because I sleep on my side, I don't. Is that possible that I could fix sleep apnea? That you could have so mild a case that if you don't sleep on your back, you no longer have sleep apnea? Because I'm wondering, do I like to sleep on my side because I like to sleep on my side, or if I just figured out that that's the best way to sleep for me? Do you understand?
Yeah, it's very profound because I think that's true. I think there are people, as from childhood, you learn not to sleep on your back. It's better for you not to sleep on your back. Right. Your brain just trains you to sleep on your side. So yes, and in fact, there's something called positional sleep apnea where people just really have sleep apnea when they sleep on their back.
Then I have it. Yeah.
And it's I'm sure I have it. It's a milder kind of version of sleep apnea, we think, but it's sleep apnea. So,
so let's say you have a person, like I believe I am, who has positional sleep apnea.
Right.
Can I solve it by just sleeping on my side? I mean, is that problem solved? No CPAP needed? Is that cool?
That's possible, yeah.
So so anybody who snores, Chad, do you sleep on your back? What is your deal? Do you sleep on your back?
No, I definitely sleep on my side.
So he sleeps. How does he still snore if he sleeps on his side? You snore, yes?
Yeah, I've been accused a few times.
How does he snore if he sleeps on his side? I don't understand.
Throat is still narrow and still collapsible when you sleep on your side. I mean, I'm trying to say is that we're all different. We're all built differently, and so some people have some narrowing, but it only becomes a problem when you sleep on your back.
Okay.
And I will say this. I mean, to my unhealthy sleep habits, I will fall asleep watching the television, so I am sitting up.
Okay.
Until I have, and then I would usually get a kick or something, at which point I'm definitely sleeping on my back, snoring, but my preferred sleep position is on my side.
Do you think you snore on your side?
I'll tape my sleep tonight and let you
We
know.
got to get this Snore Lab app. Seriously, Chad, we got to do.
I put it on my phone already.
Yeah, I'm in Snore Lab. I'm just curious to see if okay. All right. So positioning, doctor. You also say oral appliances. Would that be similar to the one for snoring, where it pulls your jaw forward?
Yeah, it's the same idea. Usually for sleep apnea, first of all, insurance companies, private insurance, commercial carriers actually pay for them. Medicare pays for them.
Okay.
So that's actually why I started actually doing them myself. Because they can be covered by patients' insurance, and very often patients who are having a hard time finding a participating dentist who would accept the payment from the insurance.
You do it.
So I do it as well for my patients for that reason, and they work as we discussed for the appliances for snoring, and for sleep apnea we usually make them custom, meaning that they're going to be made in a dental lab from impressions or from a scan.
You take the impressions in your office.
And then they're custom fitted and they're more durable. They're very adjustable because I don't know where to place your jaw to stop your problem when I see you in the office. So I put them in a somewhat advanced position, not too much. And then at home or in the office, there's ways to adjust the appliance usually with a little key to gradually increase the forward position of the jaw.
See, to me, that seems like it would hurt. I don't know. It just sounds to me like it would hurt.
Yeah. It doesn't hurt, but again, that's exactly what I'm saying. Personalize the treatment. So you'd come in and you'd say, "No, doctor, this is not for me."
I just don't know how to relax and fall asleep with something in my. I just don't.
Right.
You know.
So that's why it's important to really listen to your patient, try to find out what you like, what you don't like, and what's going to work for you.
Now, finally, doctor, you have different. We only have about less than 10 minutes. And
Sure.
I want to give a little Tamari's tip at the end from my personal trainer perspective. But you do have surgical options. I know that you're very conservative. You said in the magazine article that, surgeries, and I love that about you, that surgery is always a last resort. I love that about you because surgeons are trained to cut. Like I always, a lot of people complain. Like a lot of my clients, they'll get injuries or something. They'll go see an orthopedic surgeon, and they'll complain when surgery is recommended, as opposed to physical therapy, acupuncture. Something. If you go to a surgeon, what are surgeons trained to do? Surgeons are trained to cut. So I like that you're very conservative, and you'd rather not do surgery.
Right, if we can, yeah. So unless there's an obvious target, like if your tonsils are huge, then that's an obvious target.
Okay.
And by removing them, you buy some very valuable real estate in the throat. So
don't most people our age have their tonsils out? Don't.
So they're not usually they're not large in adults usually.
Okay.
But sometimes they are.
Okay, because I got my tonsils out. Most people have had tonsillectomies. Yes, yeah.
Many. There was a period where it was definitely the trend.
Yeah, like growing up in
right,
my era.
right.
Yeah, my time. So you have different.
Right.
Let's just very briefly through the surgical options. Some some are jaw, which are the more the more involved ones, and then you have lesser invasive ones that work on the palate.
Sure. So the mother of all surgeries is really maxillomandibular advancement. That's jaw surgery where both jaws are advanced forward. That's a huge operation that can be very effective and maybe also a very good operation for people with a small face, but there are few people that select this approach because of its
Sounds
magnitude.
horrifying.
Yeah, it's big. Yeah. And recovery is very long. So now what changed over time in my practice, I used to do many more procedures at the same time.
Okay.
And then with the newer style of procedures that were developed by my colleagues, and obviously we all modified them over time, those are we found that these procedures that are on the upper throat that have to do usually with the side walls of the throat and the palate, they're called lateral pharyngoplasties, like plastic surgery of the throat, throat lift, you want to call it if you want, or there's another one called expansion sphincter pharyngoplasty. Those are procedures that reposition the muscles on the side of the throat and also stabilize the palate.
Okay.
And you can actually open up this bottleneck at the top of your airway and create better flow. So I found by doing these procedures, I can very often spare the need for additional procedures that I used to do. And so I love that because less is more. You don't come and ask me how much more surgery can I do for you, but how less, how fewer procedures can you. So that's been effective, and that's the mantra that I've been actually preaching to my colleagues is, put yourself in the patient's shoes, and if you can, do less because it's possible.
On what percentage of patients do you find you have to do surgery? Because I'm sure at first you do the CPAP, and then you do the stupid.
Right.
The
oral appliance.
The oral. I just think that sounds horrifying. The oral appliance. So you do all this other stuff, and then finally you say, okay, let's do surgery. How many, of every 10 patients that you have, how many? What do you end up doing surgery on? 1 out of 10?
No, it's even less than 1 out of 10. Yeah.
And also what I thought was interesting is this. Wait a second. Oh yeah, the Inspire device, the implantable device.
Right. So there's also neurostimulation. So as we said, it's muscle tone. So you can activate muscle tone by basically stimulating the nerve to the tongue.
Where is that implanted? Because this has been since 2014. It was approved by the FDA in 2014. Where's that implanted?
Right. So it's implanted in the neck. Inspire, by the way, is the one you're talking about. There's also a company called Imthera Medical, like implantable therapy, that's not yet approved in the U.S. And I've been working on that device. Almost done with the enrollment in the clinical trial. And so the idea is that there's a little stimulator that's a little cuff that's placed around a big nerve in the neck, underneath the skin.
Okay.
and it's connected to a small power source, like a pacemaker, that's placed underneath the skin and the upper chest.
Right here. Okay.
Right. So that's the ImThera system. It only has two components, and then the Inspire, which is this other company that's approved, has FDA approved, has an additional component going, a little wire going down the chest wall, again underneath the tissues, that senses breathing.
Where's
so it has
the implant?
3 parts.
Where's the implant for the Inspire? The one that's
right. So it's on the right side of the body, and it's underneath, a couple of fingers below the clavicle. Yeah.
Okay. So it's you can't see it though. You can't see it on a woman or a man.
You may see it. You may see a little bulge, or you may not.
How big is it?
So it's about we're all making size. So I would estimate it's about maybe, let's say the ImThera is about 2.5 inches by maybe 1.5 inches in terms of the
it's like
length
a small
and width.
pacemaker. Yeah.
Right. Yeah, and the width is approximately, I would estimate, I don't know, maybe half.
That's an inch.
Yeah, smaller than an inch. Yeah.
But so it's almost like a small pacemaker, and it's put in the upper part of the right chest.
Right. Yeah.
Okay, and that's an implantable device. The
device.
Inspire for CPAP for
right.
OSA.
Activates muscle tone, and the idea is, instead of taking your remote and turning off your television, you take the remote and you turn on your device to start after a little delay once you fall asleep.
Okay, so how do you like that? Because if someone, instead of having surgery, I think I'd rather have an implantable device.
Right, so it's very appealing, but again, that's you. So you said, I don't like oral appliances, but I like this idea. So some people will say, wow, I'm practically bionic now. Okay. I can't sleep without my cell phone and so on. I love this. And there are people who say, okay, that sounds really cool.
Do you leave the implantable device in permanently?
Yeah, it's left, it's left long-term, and obviously if the battery, after a decade or more, the battery needs to be changed, that's easy because that's right underneath the skin.
I think as a female, I wouldn't dig it if it showed.
Sure.
So I'd love to see a photo or something. I wish I had could see what it actually, because I know sometimes you can see pacemakers.
Right.
Yeah. That would be interesting, though.
Sure.
So that's called the Inspire medical device.
So there's Inspire, right? ImThera is the one that's not yet approved in testing in the U.S., although it's approved in Europe and in South America. And the idea is, again, that this is the new frontier, which is really exciting. We're just opening the door now, and we're learning more how to use it. Obviously, it's not going to work in everyone, but we're learning more and more how to use it and hopefully find a better candidate.
Well, I also wanted to say this, and then unfortunately we're going to have to close. So I don't think this is what you were referring to. An experimental system in preliminary testing that's applied on a patch under the chin.
Right. So actually it's similar, but a little different, because now you don't have a power source, a pacemaker that's implanted in the body.
Yeah. For me, instead of putting a device in my body, I'd rather slap something on my chin at night. Is that what we're talking about? You stick it under your chin?
So the idea, so actually you have a small procedure to implant a receiver.
Okay.
On the nerve branches that activate the muscles here in the center of the neck to the tongue. And once you have that in, then you put the external little button, which is the power source and transmitter, and you stick it right underneath your chin. And that provides the power to activate. Because
that's still experimental. That's
experimental. This is being tested now in Australia and Europe, and it's called the Genio system from Maxilla Medical. So
we'll probably see that in 2 years.
Well, it takes a while. I'm working with that research as well. So.
Now, we're going to do a little Tamari's tip. I think this has been fascinating, and this is where I put in my little 2 cents. My background is I'm a trainer and an exercise physiologist. I always look at things like this. Whatever I can do to help myself, I do. Anything I can do. So let me say this, and I say this just having worked with a lot of people in the obese and overweight population. The closer you edge your way toward being overweight or obese, the greater your risk of a lot of diseases. But sleep apnea is one of them. So the greater you edge your way, the more you edge your way toward being obese or even just in an overweight category, you increase your chances of developing sleep apnea. Compared to normal weight adults, whatever normal weight is, people who are obese have a 7 times increased risk of developing sleep apnea. I think that's really significant. And obese, if you're looking at a body mass index scale, BMI, obese is greater than 30 kilograms over meters squared. And by the way, overweight is greater than 25. Now, body mass index, I've talked about this before on the show. I don't love body mass index because all it is it's really a height-weight ratio, and it doesn't really tell you, it doesn't inform you what the weight is. And so if you're very muscular and you weigh more for your height, it doesn't take that into account. But the problem is in medicine, they talk about BMI, BMI, BMI. So you have to consider it at least, especially for a lot of the population where they're not very muscular, athletic people. It's probably safe to say you can go using BMI, but I don't love it. I did my own BMI. My BMI, based on my height and my weight, is 22. So I'm precisely 3 points away from being considered overweight.